Good morning and welcome to today's webinar. Thank you for joining us. My name is Irina Polanco Ventura and I am Director of Public Health Initiatives for the Partnership for Maternal and Child Health of Northern New Jersey, which is providing today's program. Our webinar today is titled Community Doulas, Enhancing the Care Team, Supporting Birthing People and Improving Outcomes. This program was born out of our newest initiative, Community of Caring, the Patterson Doula Cooperative, which provides free community doula training using the Health Connect One model. The Patterson Doula Cooperative is a collaboration between the Partnership, New Destiny Family Success Center, and St. Joseph's Health. So before we get started, I need to review some housekeeping items. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. We will also be muting all of the attendees' microphones during the presentation, but we will have time to conduct a short Q&A session at the end, so please write your questions in the question box throughout the presentation, and we will make sure to get to as many as possible. I am honored to first introduce Dr. Roger Kearse, Chairman of Obstetrics and Gynecology at St. Joseph's Health, and a vital member of the Patterson Doula Cooperative team, to provide a welcome and introduce our speaker. Thank you, Dr. Kearse, for being with us today, and I will go ahead and pass it along to you.
Thank you. So, as I was thinking about today, I started as an attending in 1990, and the combined section rate for myself back then, taking care of this Patterson population, was in the single digits. That's primary and repeats, and it was that way for several years. And the pendulum has changed so far over the last few years that there has to be different things that we can do to try and address this to get it back to a normal process. All these years I've been teaching the residents and the students, I've been telling them, basically it's a natural process, and this was happening long before there were hospitals and doctors and midwives, and it was a natural process. And our job is really just to oversee that process and make sure that we get a healthy outcome for the mom and the baby. And the second thing that I try and pound into them is that every intervention comes with a potential cost that's negative to the patient. Every time we do something else to the patient, it's potentially a problem. So it's fitting that we're now going in a completely different direction than St. Joe's has ever been in, and I think that the state is going with the governor's wife and Nurture New Jersey, and really putting alternatives out there that can really start to impact the empowerment of women, how they handle their pregnancies, how they handle their deliveries and their postpartum periods, and then newborn care. So I'm excited today for our speaker, Dr. Blumenfeld, who is a certified nurse midwife, International Board Certified Lactation Consultant, and fellow of the American College of Nurse Midwives. She's an assistant professor and program director of the Nurse Midwifery and the Dual Women's Health Nurse Midwifery program at Rutgers. She began her healthcare as a Peace Corps volunteer, and she spent the last 20 years providing midwifery care at Capitol Health in the southern part of our state. In addition to her commitment to the patients and the family, she is a passionate advocate for creating lasting change through health policy. She has multiple roles in the state, serving on the New Jersey Board of Medical Examiners Midwifery Liaison Committee. She's chair of the Health Equity Subcommittee. She serves as on the New Jersey Maternal Mortality Review Committee, and she's chair of the New Jersey Maternity Quality Collaborative, which is a state maternal health task force. She's actively both locally and nationally, and her credentials go on and on. Beyond that, she is an incredible bedside care provider who's an advocate and a fantastic teacher, and we're very lucky to have her today to share some of her insights, her wisdom, and get us all educated and in tune to a whole new area of obstetrical care that is foreign to many of us. Dr. Blumenfeld?
Well, thank you, Irina and Dr. Kearse, for having me here today. I'm really excited to talk to you about doulas, the research and my experience with them. So thank you to my colleagues at the Partnership, St. Joseph's University Medical Center for inviting me to speak to you about the great work that doulas do around the world over time, and particularly here in New Jersey, where, as Dr. Kearse said, we have much work to do to improve maternal health outcomes and inequities. And thinking about the title of today's talk, Community Doulas, Enhancing the Care Team, Supporting Birthing People, and Improving Outcomes, it really could have been, or maybe should have been, Partnering with Community Doulas, Enhancing the Care Team, Supporting Birthing People, and Improving Equity. I also want to thank the Children's Home Society of New Jersey for their ongoing support of the Patterson doulas and for the invitation to serve as a presenter and for always highlighting the good work that midwives do and specifically our community collaborations. And congratulations to the partnership and the hospital for their success for the doula program and getting started. And I would be remiss if I didn't congratulate them also for their recent success. I saw on social media the great work they've been doing with centering and the recognition from the Hospital Association, I believe it was, for this tremendous work. So congratulations to everyone at St. Joseph's for that work. So as Dr. Kearse mentioned, I work as a professor at Rutgers University, and I also work clinically in Trenton as a midwife, where I have for the past 20 years, and work really closely there with doulas. I've worked alongside birth workers and policymakers in the state government to pass the bill for Medicaid coverage for doula care and serve as a clinical consultant to the AMAR Spanish language community doula program. And I also served within New Jersey Medicaid on their doula stakeholder committee. So we know that the maternity care system in the United States often invests in high-tech solutions, and that seemingly simple, innovative strategies usually better outcomes. For example, outreach by community health workers and continuous labor support by doulas. And I'm really excited to talk to you about the good work that doulas do, accompanying pregnant people to prenatal visits, accompanying them in labor, supporting them in the postpartum period for weeks after they've birthed. We know that community doulas do vital work, that they're really familiar with the experience of the people they serve, and they support them at their most vulnerable time, a time of potential growth, learning, and health. Next slide, please. So the planners and I do not have any conflicts of interest to report for this activity. To receive nursing contact hours for this continuing education program, you must log into the webinar, attend the entire program, and complete and submit an online evaluation. Certificates will be distributed within 1 week after the program upon receipt of the evaluation form. This program is being recorded and will be available on the partnership's website and YouTube channel. Approval status does not imply endorsement by the Partnership for Maternal and Child Health of Northern New Jersey, NJSNA, or by ANCC of any commercial products discussed or displayed in conjunction with the educational activity. And as I mentioned, I'm a consultant with the Children's Home Society of New Jersey and their AMAR doula program, and glad to be here as part of a technical assistant effort founded by the Taub Foundation and led by the Children's Home Society of New Jersey, which operates its own doula program in Trenton at Capitol Health. Next slide, please. So the learning objectives for today's webinar are to examine the role of a cohesive birth care team in promoting physiologic birth and improving birth outcomes, examining the evidence that supports the role of doula care in improving maternal and infant health inequities, understanding the unique role of the community-based doula, and identifying successful implementation techniques that support community-based doula collaborations. And then I will touch a bit overall on the state of doulas in New Jersey and the good work that's been done in our state to support doulas and perpetuate their presence. So first, I'm going to talk about the role of the birth care team in promoting physiologic birth and improving outcomes. And then I'll move on and talk about evidence that supports the benefits of doula care and the unique role of the community-based doula, and then touch on their training and preparation, ongoing support and collaborations, and patient outcomes that happen as a result of having doula presence, and then again, state advocacy for community-based doulas in New Jersey. And then we'll have some time at the end for open discussion and questions. I want to mention that I recognize and respect that pregnant, birthing, postpartum, and parenting people have a range of gender identities and do not always identify as women or mothers. In recognition of the diversity of identities, I attempt to give preference to gender-neutral terms such as people, pregnant people, and birthing persons. In reference to studies, I use the typically gendered language of the authors. Next slide, please. So what impacts the birthing experience and birthing outcomes? We know that there are key influences on how labor and birth care proceed. Things like the birthing person's experiences and preferences, so what their prior births have been like, how they're going into the birth, what their birth plan looks like, their specific labor nurse or the provider, the obstetrician or the midwife that's caring for them, their choice of a birthing attendant, whether they have a doula or a different support person with them, the hospital where they're birthing, or whether it's a birth center or their home. And if it is a hospital, the resources that are available there and the culture within the hospital system, and certainly social determinants of health. We know that system level factors and social determinants of health, such as structural racism, lack of financial resources, availability of transportation, housing instability, lack of social support, stress, limited availability of healthy and nutritious foods, lack of education, and lack of access to healthcare, including mental health care, are correlated with higher risk for poor pregnancy outcomes and inequity in care and outcomes. So that is, wherever a person gives birth, the effects of the longitudinal, multifaceted, socially shaped health inputs that they bring to their pregnancy and continuing through and beyond maternal care influences their birth outcomes. And these system level factors, however, are modifiable, and improving maternal and newborn care in the United States requires interventions outside of the healthcare system. We know that there are things that can positively impact the birthing experience at many different levels, including for healthcare providers, spending quality time with the people they're caring for, relationship building and making meaningful connections, individualized person-centered care, and partnership in decision-making. And at the systems level, at the hospital level, providing continuity of care. So allowing providers to have scheduling and setting up systems that allow for continuity of care for patients, racial concordance with providers and really thoughtful hiring practices, supportive healthcare system structures that meet the needs of birthing people, implicit bias training and educations that reduce judgment, stereotyping, and discrimination, and expanding the concept of the birthing team to include people like doulas and the birthing person themselves. It sits, as you see in the slide, right at the center. Next slide, please. So according to the Institute of Medicine, what is person-centered care? Providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Envisioning a transformed maternal and newborn care system that places birthing people and their infants at the center, just like we were discussing and was depicted in the prior slide, is the goal. In such a system, policies and structures are based on the best interest of that birthing person. Available care is matched to the physical, emotional, social needs, the preferences, needs, and life circumstances of the birthing person and their fetus and their infant. Ultimately, this will limit overuse of unneeded care and underuse of beneficial care. And doulas, who typically center the patient, can be a huge help, steering us towards this model of care. And this is particularly impactful for community doulas, which we will get to shortly and talk about at length in the presentation, who provide low or no cost care to populations who historically have been denied a voice in their healthcare, including under-resourced communities, Black birthing people, and other people of color. Next slide, please. So what is doula care? What is the role of the doula? Doulas provide non-clinical, emotional, physical, and informational support before, during, and after birth, during the prenatal and postpartum periods, and during labor and birth. They focus on only one laboring person at a time, and they provide continuous support without any other responsibilities. They do not do clinical tasks. They support the birthing person, their partner, and their family. In the postpartum period, they assist with breastfeeding and newborn care, and some doulas also support people through miscarriages, stillbirths, and abortions. The partnership website says it perfectly. Doulas are trained to give emotional, physical, and informational care during pregnancy, childbirth, and the postpartum period. Doulas are members of your community who can be trusted to advocate for your needs. Doulas are respected members of the pregnancy care team, providing advocacy and support to parents. And doulas help improve birth outcomes and breastfeeding rates, setting up families for success. My experience over the past several years, I'm working with doulas, and there are 3 established doula programs now collaborating with patients at Capitol Health where I work clinically, is that hospital staff now know them by name. They welcome them into the hospital. They look forward to having them there. And what I see from the doula perspective is that they're coming to more and more prenatal visits with patients. They're there in labor and they're staying. They are helping patients to ask questions, and their presence has been incredibly positive. Next slide, please. So I'm going to give a bit of a historic perspective and then review the current literature, just to showing the support for doulas and the good work they do. So the early origins of the term doula are traced back to ancient Greece. And this demonstrates the long-held belief that pregnant people need others to nurture them when they're pregnant, when they're in labor, and during the postpartum period. And this role exists across the globe and across cultures. The modern use of the word was first used in published literature in the early 1970s when an anthropologist named Dana Raphael used the term, referring to supportive care during pregnancy and childbirth, specifically with regards to breastfeeding. She described the role as mothering the mother, and she wrote that this support was imperative for successful breastfeeding, successful infant attachment, and early parenting success. In the 1980s, John Kennel and Marshall Klaus, who were already interested in maternal-infant bonding post-birth, started to investigate the effect of the presence of supportive individuals during the birthing period on both the mother and on the infant. And they did a foundational study conducted in Guatemala that was published in the New England Journal of Medicine in 1980. And in their study, there were 2 women that provided support to an experimental group of laboring women via presence, touch, and verbal encouragement. And their outcomes included shorter total time in labor, fewer medical interventions, and more positive interactions with infants in the immediate postpartum period, for example, smiling and talking. And they concluded that ongoing support to laboring individuals has noteworthy and accessible benefits to the birthing person and their infant. So not only were these effects really something you could see, but something that you could measure. Their work formalized the term doula in the context of labor and birth and provoked further interest in the academic community to investigate the role of labor support on birthing people and their infants. And these same authors expanded on their original work in 1986 when they completed a similar, albeit larger study, again in Guatemala, this time with close to 500 participants. And findings were similar, that ongoing labor support again has measurable benefits, including influences on physiologic processes. Additional research leading to very similar conclusions was completed by other scholars in the 1990s in South Africa and in Mexico, and conclusions included that there was decreased report of discomfort in labor, less use of analgesia in labor, improved self-reported coping skills in labor, greater success with breastfeeding, greater rates of exclusivity of breastfeeding, and lower rates of postpartum depression. In the late 1990s, Kendall and Klaus published a meta-analysis which included randomized control trials from around the globe. And the findings of those studies showed that there was shorter duration of labor, less utilization of pharmacologic pain relief, and fewer operative deliveries. Today, the term doula generally refers to an experienced person who supports a pregnant person around the time of childbirth. Ongoing personalized care, information and advocacy, supporting a birthing person's right to be decision makers, and physical and emotional support to birthing people and their partners. Next slide, please. So more recently, Megan Boren and her colleagues published in the Cochrane Journal the most recent reviews of continuous labor support. One in 2019, which was a qualitative evidence synthesis of perceptions and experiences of labor companionship, and one in 2017 about continuous support for women during childbirth. In the 2017 review, the authors combined the results of 26 randomized trials, which included more than 15,000 people. The individuals in these studies either received continuous one-on-one support during labor or what they called usual care, and the continuous support was not necessarily provided by doulas. And the authors concluded that having a companion in labor improves both maternal and infant outcomes and is an essential component of improving quality of care for birthing people. Specific findings that they saw were there's a greater likelihood of spontaneous vaginal birth with shorter labor, less likelihood of having pain medication, epidurals, or assisted birth with vacuums or forceps, and less cesarean births. They also showed that having a doula in particular more greatly impacted several of these outcomes. So on top of the positive outcomes they saw for people that had general support in labor, people that have doulas had even further decreased rates of cesarean births and greater increase of having a greater possibility of having a spontaneous vaginal birth. Some evidence that doula support also was seen that it can decrease postpartum depression, and there was nothing negative associated with continuous labor support in their studies. In the 2019 review, the authors found 51 studies regarding labor companions, and it was mostly about birthing people's perspectives. And the principal's findings included that support from a labor companion includes sharing of information, being advocates, and providing physical and emotional support, and contributes to a positive birth experience. And I think what's really impactful about that is that people often think of doulas as providing that physical and emotional support, and that possibly it includes to positive birth outcomes. But we now know that there's a really big piece of this sharing of information and being a patient advocate, which is equally important. Next slide, please. So why are doulas effective? Dr. Rebecca Decker, who many of you may know from her website and podcast, Evidence-Based Birth, has developed a conceptual model depicting how doula care, continuous labor support, works. Typically, it will increase a patient's mobility and self-esteem and decrease anxiety. And this in turn will decrease pain and subsequent utilization, for example, of epidurals and other interventions like Pitocin. We know that increased mobility and oxytocin release decrease labor duration, also leading to decreased use of Pitocin. And this in turn leads to increased rates of spontaneous vaginal birth, decrease in cesarean birth, and improved infant outcomes and increased patient satisfaction. Next slide, please. So I wanted to share some of the words of my colleagues, obstetricians and midwives that I work with, to get a sense of their thoughts and feelings after working with doulas over the past 3 years about the collaborations that they've had. So some things that people said when I asked them were, I'm always happy to see doulas present at a birth because I know the laboring woman is in good hands and she will have continuous care and support that she needs. The huge advantage to having a doula present is that there's constant support in the room. For example, when I want to encourage a patient to be out of bed and moving, the doula is great at facilitating this. Others were that every mom who wants a doula should have easy access. Next slide, please. I love working with these doulas. They're partners in care with us. It's a mutually respectful and collaborative relationship. I've learned so much from them. More importantly, they empower an often challenged population. I've seen so much good done by these women. Next slide, please. And finally, doulas act as advocates for the patient. They provide emotional and physical support and encouragement. They have a special connection with their patients, which serves as a bridge for communication between the patient and the healthcare providers. I'd love to see the continuous support that doulas provide, especially for Spanish-speaking patients. You can see the special bond that the doula and the patient have created. Next slide, please. So Black birthing people, we know, experience higher rates of poor birth outcomes nationally and in New Jersey, where we live and work. And racism influences social determinants of health, the neighborhood and the lived environment, education and economic stability. And social determinants of health impact maternal and infant health outcomes. Casey Kozemanil at the University of Minnesota in 2016 investigated the role of doulas in mitigating some of these inequities. The goal of the study that she and her colleagues undertook was to ascertain how having the support of a doula might impact pregnancy and birth of racially and ethnically diverse low-income pregnant people. And they used focus groups to elicit the thoughts and feelings of women who had had doula care. What their outcomes showed was that doulas in the studies provided information and social support, and this resulted in greater access to and improved quality of care. The authors grouped the participants' description of the impact of the doulas into several broad categories. And these included agency, connectedness, personal security, which is especially important for individuals with complex social situations, respect, and knowledge. And what they showed was that by increasing agency, or an individual's belief in their ability to make choices for themselves, and knowledge, doulas improved communication between pregnant people and their providers. And underlying many of these themes is having someone knowledgeable and also who has culturally congruent beliefs. And the authors concluded that doulas are a social support intervention that can interrupt the impact of social determinants of health on pregnancy and on birth, and that clinicians and clinical efforts have not been successful in addressing. So we've tried to address these issues, we haven't been particularly successful, but that doulas and their social support can be, and that this improves birth outcomes. This qualitative study is a unique contribution to the literature on doula care that really historically is focused on white upper middle class women and often in randomized control studies rather than qualitative research. Individuals in the study specifically commented on the benefit of receiving care and support during birth from individuals who share their culture and their community. And the authors point out that one barrier to doula care across the United States for low-income people is reimbursement, and particularly in Medicaid. And we're going to talk about this a little bit, but it certainly is a place where New Jersey has been successful, and now doulas can be reimbursed through Medicaid. Next slide, please. So traditional doula organizations historically have not centered on the leadership, voices, or experiences of people of color or on low-income communities. And these are key tenets of community-based doula organizations. So now we're going to switch gears and talk some more about community doulas. Community doulas make traditional doula care accessible and appropriate for underserved communities. They live in the communities where they serve, they share the background, the culture, and the language of their clients, and they meet individuals in their homes, in prenatal offices, or in community settings. And their services go beyond what traditional doula services have offered. They're becoming more utilized resource. Many community-based perinatal healthcare worker organizations are forming across the country to provide culturally congruent support to childbearing people and families in where standard maternity services do exist, but outcomes are poor. They're rooted in social, reproductive, and birthing justice frameworks. They recognize that people of color face systemic racism, inequities, and other barriers. They work to provide trauma-informed, multi-generational support that's tailored to communities and individuals, and they focus on respect, empowerment, and choice without judgment. Their training typically focuses on areas that you would think, like labor, breastfeeding, and parenting support, but also on mental health and referral to needed social and community services. Community-based doulas combine the role of a community health worker with that of the traditional doula, and they consider the cultural context where childbirth occurs. The relationship isn't solely about the birth experience, but also about a trusting, supportive relationship with the pregnant person and their family that begins during pregnancy and extends into the postpartum period, helping create a nurturing environment for a newborn. Community doulas provide family-centered support. And this support from care from individuals within the same community as the birthing person is really meaningful for individuals and ultimately strengthens their shared community. Next slide, please. In their 2022 manuscript, Listening to Women, Recommendations from Women of Color to Improve Experiences in Pregnancy and Birth Care, Altman and their colleagues used qualitative research strategies to describe and categorize recommendations to improve pregnancy and birth care made by women of color from their own experiences of perinatal health care. And this is what the authors say in their study, that some women experience a gap between the care they expect and want and the care they receive. Women want safety, freedom of choice in birth setting and provider, choice among care practices, and respectful treatment. Individual expectations, the amount of support received from caregivers, the quality of the caregiver-patient relationship, and involvement in decision-making appear to be the greatest influences on women's satisfaction with the experience of childbirth. And these findings are easily extrapolated to demonstrate the potential role of the community doula for improving outcomes given our current model of care. Community doulas and the patient experience show that they spend more quality time, they build relationships and make meaningful connections, they provide that individualized patient-centered care, they are partners in decision-making, they provide tremendous continuity of care, they attend prenatal visits, there's a lot of contact before the birth, they attend the birth and stay in contact for many, many weeks after the baby is born. There's racial concordance, and these community doulas are trained with implicit bias trainings. Next slide, please. Recently, researchers at the University of California in Berkeley and the University of California, San Francisco partnered with community doula leaders on a project designed to facilitate equitable and ethical research on community doula care in California. And as part of their project, they described community doulas, why they're essential, and why further research should be focused on the work they do. And they write that community doulas respect their communities. They're familiar with their clients' experiences, with their challenges, and they build lasting relationships. Community doulas serve populations who historically have not had any input into their care, including under-resourced communities, Black birthing people, and other people of color. They listen, they facilitate conversations with providers, they dismantle the effects of racism and bias in maternity care that lead to inequities in maternal health. They connect clients to resources. They're very familiar with the community where the clients are from and where they're working, things like food resources and baby care items and mental health resources and support for infant feeding. They collaborate with the patient, they collaborate with the care provider, they collaborate with community resources, and they are valuable, educated, and trained. And we will go into this in more detail as the presentation goes on. Next slide, please. In their book, The Community-Based Doula, Supporting Families Before, During, and After Childbirth, about community-based doulas in Chicago, Rachel Abramson and her colleagues write about community doulas in the early 2000s, and their program was the precursor to the Health Connect One model used to train the doulas in Patterson and in Trenton. And Health Connect One is an organization that's really at the forefront of supporting community doulas. And this is one of my all-time favorite quotes about doulas that I will share with you. Being with another person in her time of need, standing firmly in one's own strength and helping the person in need find hers is the ultimate human act. It is the essence of relationship-based work. Strong, caring relationships nurture babies, and these same positive relationships keep adults vital and learning. In nurturing that human potential, doulas expand their own potential as well. Thus, the community-based doula model is also a community development strategy. Building communities that stand together give us hope for the future and is the most essential form of family support. Next slide, please. So Health Connect One model for community doulas is a national leader training and supporting the work of community doulas. And again, it's the specific training used here with a partnership. Their tenets include employing doulas from the community, collaborating with community stakeholders, and including local prenatal services and hospitals. A training curriculum that's based on popular education techniques, including a diverse group of people with different expertise that can be a resource for the trainings, and collaborating with community stakeholders and institutions to use a very diverse team approach. And they also provide equitable salaries or promote providing equitable salaries and support for doulas as part of a workforce development effort. So it's not just about doulas supporting the birthing people, but providing support for those doulas as well. Next slide, please. So I'm going to speak a bit about the preparation of community doulas to provide some context for the good work that they do. The training model focuses on connecting with members of the community, finding people that are trusted members of the community, that understand the community and have a passion to serve, and then orienting them to the job of the doula and what the position will entail. In New Jersey, under New Jersey Family Care, Medicaid, doula services are delivered by providers with community doula training from approved training programs, and community doulas are equipped to meet the particular needs of the New Jersey Family Care members and other underserved communities. So some community-based doula training programs are approved with no additional training needed, for example, the programs like New Jersey Health Connect One. And then there are providers with some other sources of doula training that are nationally recognized, like DONA or CAPA, and then they need to meet some other specific requirements to be eligible to be covered under New Jersey Medicaid. For example, learning about community-based resources and cultural competency training. And one of the goals of this training is to ensure that doulas can provide information about New Jersey-specific community-based resources to their clients. Next slide, please. So the Health Connect One training is a 5-month training. It's 20 interactive sessions and numerous clinical observations, including on labor and birth, attending prenatal visits and observing them, postpartum visits, attending childbirth classes, and also breastfeeding classes. And if you look at the slide, it looks like a lot of fun. The trainings are informative, interactive, and fabulous opportunities for doulas to interact, ask questions, get to know each other. Next slide, please. So they learn hands-on comfort measures, resources and information about labor and birth, strategies to facilitate positive communication between birthing people and their care providers, and helping people articulate their questions, their preferences, and their values. They learn how to help with newborn feeding and care, emotional and physical recovery from birth, and coping skills. Like all doulas, they learn about anatomy and physiology as related to the childbearing process, the capacity to employ different kinds of strategies for providing emotional support and resources, skills for labor coping strategies, again, strategies to foster effective communication, awareness about allopathic and holistic healthcare systems and different modalities of care that doulas can refer clients to address different kinds of issues they're having, and knowledge and strategies for supporting human milk feeding, breastfeeding, and lactation. And then they also learn about social determinants of health and how to access local resources they may or may not already be aware of, things like transportation assistance, financial support, mental health resources, substance abuse counseling, access to different kinds of healthcare services and insurance, housing assistance, immigration assistance, understanding the process and importance of making referrals to appropriate social support services like WIC, housing and case management, cultural sensitivity to the lived experience of people in their community, people in low-income communities, and understanding the impact of structural racism and implicit bias and the role they have in accessing care, experiences of care, and birth outcomes. And they learn about modalities of practice that are culturally sensitive and relevant to the pregnant person's needs based on understanding the experiences that may reflect societal, institutional, or interpersonal bias. And they learn about cultural humility and recognizing the intersection of the needs of the childbearing person across the reproductive health spectrum. So way beyond what people would typically consider the things that a doula would learn in their training. Next slide, please. They have hours of hands-on simulation about diverse topics and learn how to best support people in their pregnancy, during labor, and the postpartum training. And then after training, they have tremendous amount of ongoing support and mentorship. Next slide, please. So I'm going to switch gears a bit and talk about how birthing hospitals can be a welcoming environment for the community doula to leverage this tremendous resource in New Jersey. It's apparent that when hospitals are a welcoming place for community doulas, implementing a doula project becomes an easier lift and a natural fit. And this is done by ensuring that doulas are seen as an essential part of the perinatal healthcare team. For example, recognizing doulas as trained professionals. So knowing that doulas are there to do the work they are trained to do, just like healthcare providers at any kind of hospital setting, and that they have evidence-based training to do this. Knowing that it's not a novel idea, that the benefits are apparent, and as I discussed, this is evidence-based. And so there's improved patient experience and improved clinical outcomes. And people often think of doulas being that one special person there to support the birthing person, but besides being the one special person, it's a special person from their community and with training. So hospital personnel should appreciate their presence as a patient advocate. And for example, if a pregnant person were to say, I need a little more time to consider whatever they want to be considering, or can you please elaborate on that explanation about whatever it is that they need more information about, a patient may be doing this with encouragement from their doula, and we can see it as added value, improving the patient's overall experience, and also with humility in our part, engaging in this discussion with the doula and the patient. Another example is assisting with facilitating integration into the healthcare setting. And this can mean breaking down silos, so introducing doulas to the office and the hospital setting and staff, including them in events and conversations in an informal setting, so something as simple as inviting them to a lunch you may have in the outpatient setting, and including them in decision-making about unit policy and structures that they may have insight into. And this may look really different for hospital systems that aren't accustomed to including people from the community, and then creating a doula policy that clearly defines their role and speaks to them as an integral part of the healthcare team as an asset. Next slide, please. So this is an example of a piece of a doula policy, and I've highlighted the part that I particularly love, and it reads, the doula is permitted to perform the services that they are trained to provide. So this is a provider that has a scope of practice, and they are going to provide services within their scope. Next slide, please. And finally, providing support for their presence. So things as simple as, recognizing their role as a patient advocate, helping facilitate communication by engaging with them, and recognizing things like that they have an important presence in the hospital. So I can give an example, for example, during COVID, when, we were sort of navigating really uncertain waters, and we limited how many people could be with birthing people. And then the Department of Health said, really the doula is an essential healthcare person, and they need to be added as an additional person, not just that one family member that's with a birthing person. So advocating for doulas in that way, advocating for them in terms of them being shift work, that it would be appropriate for them, even if you're saying the support person for the birthing person needs to come and stay, that a doula can switch out with a different doula at the end of their 12 or 24-hour shift, just like we would do. Topical updates for doulas. So picking a champion within the hospital system to provide information to doulas on some kind of regular standing basis, whether that's every month or every quarter. Things, topics that doulas have reached out and wanted information are things like, what is an external cephalic version? Maybe something that they have been totally unfamiliar with that they can advocate for and talk to patients about, or what is the role for human milk feeding when a newborn is jaundiced? So any kind of clinical topic that they could help patients understand better, be an advocate for, but they might not have information for, and it's a way to engage with the doulas in the hospital system to make them really feel like they're part of the team. Next slide, please. So one of the most effective tools to improve labor and delivery is the continuous presence of support of personnel such as a doula. Next slide, please. So looking at outcomes, what can people expect when they incorporate doulas into their healthcare system? So looking at patient outcomes measures tells a story from both an evaluation and a data perspective. When doulas are present in the literature, and what we've seen in hospitals across New Jersey is that there's increased attendance at prenatal and postpartum visits, increased full-term births, increased exclusivity of breastfeeding, and increased satisfaction with the overall childbirth experience, decreased cesarean birth rates, decreased rates of postpartum depression, decreased overall healthcare costs, and decreased racial and ethnic disparities in outcomes. Doula support overall helps avoid unnecessary medical procedures and the potential complications and chronic conditions that may result, reducing admissions to the neonatal intensive care unit and fostering healthy practices like breastfeeding. And nationally, policymakers increasingly view doula care as a strategy to reduce racial and ethnic disparities in maternal and infant health outcomes and decrease healthcare costs. Outcome measures seen in doula programs and hospital systems typically exceed those set by the hospital system themselves and by the state. Some specific outcomes that we've seen in Trenton that we've looked at are definitively increased rates of breastfeeding and increased rates of attendance at visits, earlier entrance into prenatal care, and greater attendance at postpartum visits. And then there are elements that can't be measured in numbers. So pregnant people speaking up, asking more clarifying questions, getting more information about their care, people who might otherwise be alone in labor and now having someone there by their side and with them, which we know makes a tremendous difference, impact, and increased attendance at postpartum visits, increased rates of breastfeeding, and more people requesting to participate in the doula training, excited to support people in their community. So not just increased people asking for doulas, but increased people asking to be doulas. And hospital staff knowing who doulas are. So when doulas come in, knowing them by name, welcoming their present, wanting them there, and trusting them. Next slide, please. So despite ample evidence on the effectiveness of doula care in minimizing health disparities for birthing people, some do remain hesitant to collaborate with doulas. And why is this? Well, we are unaccustomed to community-based non-medical health interventions for labor and birth. It's not the culture that we're typically accustomed to in the United States. And so how can we promote adoption of doula care? Well, through policy changes, and we've seen that in New Jersey, right? State level reimbursement and hospital level policies, and through advocacy and outreach. And this is both institutional change and cultural change. So institutional change is policy and procedural changes at the state and hospital level. And cultural change implies buy-in from medical professionals and hospital staff. And really, this is a team effort working towards a common goal, educating each other about the roles of community-based doula care and improving health outcomes and social justice. And there's room for everyone at the table. The birthing person's experience is shaped by all members of the team and is enhanced if we explicitly share the same common goal. And that goal should be provide a birthing experience that is safe, culturally appropriate, and respectful. Next slide, please. So I would be remiss if I did not circle back and touch on the larger doula initiatives in New Jersey that have been ongoing for the past several years. They were developed with numerous other initiatives in New Jersey as part of First Lady Tammy Murphy's Nurture New Jersey strategic plan. And these are efforts to mitigate the rising maternal mortality rates and racial disparities in New Jersey. And this started in July of 2018 when the Department of Health devoted almost $500,000 to implement 4 doula pilot programs in municipalities with high Black infant mortality rates, and includes funding also for independent evaluators to examine the effectiveness of this program related to birth outcomes. And then Medicaid coverage for doula care, which became law in May of 2019. And I want to give some context for this legislation because it was incredibly progressive. At the time it was passed, only Minnesota and Oregon covered doula services for all Medicaid recipients, and New York had a pilot program that ran in a couple of counties. Additionally, as directed by their state legislator, Virginia and Washington had submitted reports and studies on implementation of Medicaid reimbursement. But now doulas and other birth workers have continued to rise in popularity as potential interventions for addressing maternal health and mortality crisis in the United States. And in 2021, there was an abundance of state bills for Medicaid coverage for doula care across the United States. And since then, more than 28 bills have been introduced in states across the United States and in Washington, D.C. Numerous states ranging from California to Rhode Island have introduced bills. And the bills have not only focused on Medicaid coverage for doulas, but also creating doula registries so that doulas can communicate with each other and people can find doula services in the community where they live, a certification process for doulas, and doula care commissions that provide things like recommendations on implementation and evaluation of doula care reimbursement, recommendations for doula competencies, standards of proof, recommendations for doula training, workforce development strategies, and guidelines for increasing reimbursement. As I mentioned, the doulas that serve in Medicaid in New Jersey must be trained to provide culturally competent care that supports the diversity of its members and also assist members with community-based services in addition to the typical doula care you would expect. And New Jersey's formed a doula learning collaborative. So there are partners, the National Doula Network, Health Connect One, the partnership, also the Central Jersey Family Health Consortium and the Southern New Jersey Perinatal Cooperative. And this collaborative is committed to addressing maternal health care disparities, empowering maternal health advocates, and consciously including doulas in the conversation and work to create systemic change for families and communities throughout our state. Their goals are to reduce maternal and infant mortality and eliminate racial disparities in health outcomes by providing services for doulas, training, workforce development, reflective supervision, mentoring, technical assistance, billing, help with billing, and sustainability planning to continue community doulas and doula organizations throughout the state. They just had their first conference, and the theme was connecting with community. It was an opportunity to celebrate the New Jersey Doula Learning Collaborative, their journey, and highlight the work of the community-based doulas in our state and aspiring community-based doulas like the ones in Patterson that are in training, an opportunity for them to network, learn, and be celebrated for the vital work they do. And so, great work is being done across the whole state to expand the presence of doulas. So thank you so much for this opportunity, and I welcome the opportunity to answer any questions you might have.
Thank you so much, Julie. I really appreciated your presentation. Very detailed, wonderful, absolutely wonderful. Thank you so much. We do have some time to take some questions from the audience, and the question box is still open. So if you have any questions for Dr. Blumenfield, Dr. Kearse, please go ahead and feel free to submit your questions. There are a few that I have here. So I'll start off by, let's see. During your presentation, Julie, you did mention, you did make mention of doula policies. So the question is, does your facility have a doula policy? Are there benefits to having one? And what should that look like?
Yeah, so our hospital did have a doula policy. They'd had one for years, and then when the state became more active and we started having more community doulas in the hospital, we redid the policy, which I don't think anyone had looked at for a really long time. I'm not even sure how or when it got started, but it was updated. And the idea of the policy now really was to reflect the state's recognition of doulas and how they really are incorporated as part of the healthcare team. So that doulas are trained and that there is criteria for being a doula, and then they have that scope of practice and they should practice within it. I think some hospitals, without knowing or even realizing, might make a policy that's defensive, talking about what doulas can't do. But we know that the policy really should be something where if someone who isn't familiar with doula, like a nurse, for example, who's never heard of a doula, sees that policy, they would have a positive impression. So they wouldn't think that it was someone who is going to come in and undermine things that people are doing, but rather be a collaborative member of the healthcare team, be there to make a difference and want to be part of the system.
Thank you for your perspective. Dr. Kearse, I know that we worked under the Patterson Doula Cooperative with St. Joseph's Health to create a doula policy at St. Joseph's. Do you mind sharing a little bit about that experience?
Yeah, I think, what was discussed is that you have to have buy-in at the hospital, right? So this is purely a cultural change. I've been in the same place since 1985, and, the doulas were always in the past one-offs. So they were just not incorporated in part of the team. And then that's an alienation process, and that's just a terrible way to try and approach things, because it's not us against them. We're all about the patient, right? So we're all advocating about it. So I think that was the first step, to say that just because you have an MD and you're in the tower doesn't mean that you have any idea what the community is bringing into the hospital. And their daily baggage that they're bringing in is so different than a lot of the providers, that you need that liaison. You need somebody that has a degree of trust. So I see it as the doulas trusting the healthcare people, and then the healthcare people trusting the doulas. So that way, that aligns those two, so that both sides have the back of the patient. And I think the importance of the policy is to make it non-restrictive and simple. The actual body of the policy, I think, fits on half of a page. The entire policy with the headers and everything is a page, right? So it's inclusivity, it's not exclusion, or else it's not going to work. And I think, it's grassroots. You have to get buy-in, like anything else that you try and change within the hospital, because there's so many different facets. But it's doable. I mean, we're excited. We're into it. I mean, the centering pregnancy has been phenomenal. The results have been envious of what the midwives have been able to accomplish, and really reset the normalcy of pregnancy and delivery. I mean, it's just fantastic. And I even said to my CEO, could we just maybe replace the entire obstetrical medical staff with midwives? And he actually said, well, we can look into at least, really building it up. And so we're looking at plans to really do that, because I don't think anybody that's on this call is happy with the healthcare that's being offered in New Jersey in terms of the disparities and where we rank in the United States, let alone where the United States ranks in the world in terms of outcomes, spending so much money, the high-tech stuff, and just doing a job that just is not getting better. So these alternatives like doulas is just a great adjunct to try and chip away at the unnecessary interventions and procedures that are done, and make people feel good about being pregnant and feeling like they can enter an institution knowing when they leave that they're going to be intact, healthy, and start with a healthy outcome to their family.
And Irina, I should say that if people were interested and wanted to see the policy, I'm glad to share what we developed.
Likewise.
Thank you. Thank you to both. I'm just going to share a comment here from one of the attendees. Being a community doula for almost 4 years, I am now starting to see buy-in from providers. It is the most important connection to be made for positive maternal health innovations. Thank you for sharing that. And there is another question that kind of builds on the first question. Do you have recommendations on how to build that respectful relationship between the doulas and healthcare team when there is no history of working with doulas?
Yeah, so I think one suggestion that I can think of is find a champion. So that one person in the hospital system, it could be the CEO who, they had a doula at their birth, or a family member. It could be a midwife in the system. It could be a physician. It could be anyone, but someone who believes in doula care, or that you could have a conversation with, or connect that one person to someone who they could open up their mind to doula care, and let that person talk to their colleagues and introduce it to the hospital, I think is really one strategy anyway that is potentially helpful. And also trusted community partners that really believe in doula care. So community partners that have relationships with the hospital on other issues and other things, and then that community partner believes in doulas and can take it to the hospital system. So a couple different strategies.
I think, Julie, you just described the Patterson Doula Cooperative. This couldn't happen without the championship of Dr. Kearse, the leadership and his vision, along with Debbie Katz and the rest of the midwifery team and Centering Pregnancy. And of course, our strong collaboration with New Destiny Family Success Center, which is already a trusted member of the Patterson community. I think, that's why this program, sets itself up to be very successful, because we do have two strong pillars of the community, very active and participating 100% in this program. So thank you for sharing that. I'll go on with the next question. How can we work towards ensuring that more doulas are involved under New Jersey family care? It seems to be a complex process.
Yeah, so I encourage people to reach out to the Doula Learning Collaborative. I think that it's a great liaison. They know that this is challenging, and they have a great consultant in place to help with this. So I just hope that doulas in New Jersey don't feel like they're sort of on their own trying to sort it out, that the state has put this resource in place, and I encourage them. And if anyone has trouble, reaching out, I think they're pretty accessible on the internet, but if anyone is having trouble, I'd be glad to try and make a connection for them.
Thank you. And I just want to also share another comment. It's great to hear such positive feedback from a medical provider. Thank you, Dr. Kearse. Great work and accomplishments at St. Joseph's. Absolutely, thank you. Okay, let's see this. Another question. Oh, lessons learned during the pandemic. And I know both of you can certainly share some light with this. How has that changed your work in the hospital setting, specifically with doulas during these last few years?
So I think that it's been a great example for people to see that doulas are part of the healthcare team, so that when policies were put into place about restricting public access to the hospitals, the doulas are not a member of the public, that they're an essential part of the team. So as I mentioned in the presentation, when public access to hospitals was limited and birthing people could only have one person, that doula was an additional presence, not just that one person, which then sort of changes the thought and the culture within the hospital about how they think about doulas, because they realize that they aren't just a member of the public, but they're an essential member of the team. And this exception is being made, or this rule is being put in place, which came straight from the Department of Health with a memo sent to all hospitals, that doulas are important and they need to be allowed in. And then I think the shift work was another example where, again, doulas were told, once you're there, you can't change out with another doula because we don't want people coming and going from the hospital. And then quickly hospitals began to change that policy, recognizing that they have an essential presence. They are part of the healthcare team just like us. We change out after 12 or 24 hours, whatever our shift is, and that they need to do the same.
Thank you, Dr. Kearse. Do you have anything to add on to that?
Yes, so I think COVID really was an interesting mirror to hold up to the medical community and see how you would be defined as a community when people look back on this a year, 2 or 3 years, from the beginning of it. I think that the most important thing about COVID that I learned in a hospital was that you're capable of doing many different roles, and there's many different aspects, right? We had VPs of the hospital going to the nursing home and feeding the patients because there were no nurses' aides. We had physicians, MDs, residents, midwives being nurses' aides on floors because there was nobody around, there was no people. So when you start having that attitude that many different people can contribute different aspects of it, COVID was very humbling. It was a humbling experience to see that the spirit within the hospital, I mean, it was scary when we first started it because there was people dying, there were refrigerator trucks, there was no medication, there was no vaccines, you know, and the healthcare team really came in and, you know, stood up and was adaptable enough to do the roles, to get the patients through it, and the collegiality among everybody. There was a really good team concept. So I think, you know, I think the timing is perfect when you see doulas coming in, because it's another aspect, and the community, you know, people are bleeding out of medicine in the United States. CEOs are retiring, people that are near retirement are leaving, people have really bled out because of the circumstances. So this is an ideal opportunity for the people that have stayed, that are rolling up their sleeves and still getting dirty, that you have additional members from the community coming in to be part of the team, because they do a vital role and they can do a lot of the things better than we can do, because they have less time constraints, because they're at the bedside with the patient. And that's their only focus. They don't have to worry about the other laboring patients, labor and delivery, or the phone calls or everything else. So to be able to have somebody to keep that focus and the attention, I think it's just going to be phenomenal. I think COVID allowed us to be open to this kind of adaptability.
Thank you, Dr. Kearse. I really appreciate you sharing, you know, your experience at the hospital and your perspective. Very important. So we are at 12 o'clock, and I think that is all we have time for today. Any closing statements by you, Dr. Blumenfield, Dr. Kearse? Any last
I just want to thank you for the opportunity. I'm so glad to be collaborating. Best of luck. I'm really excited to hear about the doula program in Patterson and how it goes. And just that if anyone in the audience wants information, please feel free to reach out. I'm glad to make any connections or help however I can.
Great, great. Thank you so much. So many thanks to Dr. Kearse and our speaker, Dr. Julie Blumenfeld, and to all of you who have joined today. Just a reminder that you will receive a link to the program evaluation. And again, your feedback is important, so please take the time to complete it. And certificates of completion will be sent via the email you provide on the evaluation. So just make sure that is correct. And you should receive that in about a week. A calendar of the partnership's upcoming virtual programs can be found on our website under the Professional Education tab. And please join us for our next webinar series for National Breastfeeding Month. Every Thursday in August at 2 p.m., we will be hosting nationally renowned speakers to present on timely topics in lactation. And also, if you'd like to learn more information about the community of caring, the Patterson Doula Cooperative, please visit the program's website at www.pmch.org/doula. And I would also like to extend my deepest gratitude to the funders of the Patterson Doula Cooperative Project, the Burke Foundation, Todd Foundation, and the Terrell Fund, and their generous support on all levels. And again, thank you to both for being with me today here, and thank you to all. We hope you can join us again for upcoming education and events. Have a wonderful day and be well. Thank you.
Thank you.
Thank you. Take care.
You too.